Hamad. Unfortunately, we'll have to stop at this point with the questions as we have to move onwards. Now moving onwards, and actually before I move onwards, I'll just take a minute to thank everyone, Dr. Saad Mahdi and his team behind this outstanding, distinguished course. Thank you very much for all your efforts. And thank you for all the presenters today, all these shining stars. So moving onwards, please allow me to welcome and introduce another shining star with us tonight, Dr. Yasser Reda. Dr. Yasser Reda is a senior consultant in anesthesia and chronic pain management at Hamad Medical Corporate in Qatar. He is also the head of the intervention of pain medicine in the same corporate. He's got long-standing history in regional anesthesia, pain management. He's got the Arab Board of Anesthesia and Intensive Care. He's got the European Diploma Anesthesia, the European Diploma of Regional Anesthesia, Fellowship of Interventional Pain Practice. I can see loads and loads and loads of certifications in pain, besides his international speaking activity. Tonight, he is going to shed some light on a very interesting and important topic in our daily practice. It is the local anesthesia systemic toxicity from history to practice. Dr. Yasser, please go ahead.
Thank you, Dr. Arbab. Thank you so much for giving me this precious opportunity to share my knowledge with you in this important topic. I will try to be as long as possible to cover the subject and as short as possible, not to get bored or to fall asleep. When I started my career in anesthesia in 1994, I don't know anything about this topic because it's not raised to the surface. And this plethora of using a local anesthesia by everyone, not like just an anesthesiologist, also by non-anesthesiologists like an emergency doctors, nurses, and surgeons. And the plethora of narcotic crisis and the ERAs and the multimodal analgesia and the big amount of local anesthesia used now. So nothing is tax-free. When this come into the practice, many complications happen. And one of the most devastating complications is local anesthesia systemic toxicity. So it is a time to know why it happened and how to prevent, because prevention more better than cure, and how to diagnose. And if it happened, how can you treat, and more than information in my topic. This is my beautiful city in Ras Al Bar. And this is a join of the Nile with the Mediterranean Sea, and this is at night. I don't have any conflict of interest about my topics. Okay. So I try to make it cool as to be cool and not to be hard, because our subject usually is hard. Science is fun more than to be a very cool subject. So my objective today, how to know local anesthesia, how to know how the local anesthesia work, and how can you calculate the dose, mechanism of toxicity and mechanism of action, and why some patient get toxicity more than the other, and this is a high risk patient, and rapid discovering and management of local anesthesia toxicity, because this is affecting the outcome. Implementation of checklist quickly and efficiently, because this is a very important, like an atomic weapon industry or flight industry. Evidence about the management of local anesthesia systemic toxicity and the area of research and home message. So now regional anesthesia, as I told you, used everywhere for multimodal analgesia, for ERAs, and because they have some advantage, like decreasing the opioid dose, decreasing post-operative nausea and vomiting, decreasing length of stay, and improving patient satisfaction all the time, you know. But some people thinking this is a far away from him. No one is immune against to get an local anesthesia toxicity, even if you are very expert and you are far away, but we can attack, because you are usually playing with a shark, so there is a predicted risk. However, whatever you use in regional or anesthesia or general anesthesia, the priority is the safety, and you must look for the subject from different way. I do regional anesthesia in perfect way, but this patient not suitable, so I must look for a different way. Here in this picture, picture, if you look for other side, from other side, this is here is not this for this man. As I mean, what I mean that looking for the safety of the patient from all the aspects, not just for regional anesthesia. Anesthesia started like this as general anesthesia, and regional anesthesia have many advantages. Even here, asking him about the score during the operation, and you don't fail. And this is the global use of local anesthesia all over the continent. And you can see that North America gets the hero of using local anesthesia. After that, Europe, Asia Pacific, and Latin America, and at the end, a very minimal amount for Mediterranean. And you know that this dance, when you get and make a block and this block is working, and at the same time, when the block fade out and still the patient not feel a pain. And this is a very important moment for all the anesthesia doctor. But the moment you don't see this, what happened if any problem happened to you? And local anesthesia is a very great benefit, have a very great benefit, but systemic toxicity is still to happen. And this is the issue after the publication from a very precious Maria Cabera. This is, was a nurse, OR nurse, and she died immediately after her birth because by mistake, they put an infusion of bupivacaine in her cannula, and the patient died. And this is, there is an issue about the local anesthesia systemic toxicity. And there is the issue about how to treat this issue, how to treat this devastating complication. Because of that, you must know some fact. You know, you must know how to calculate the dose for local regional anesthesia, and it's very important. But to remember, this is a very complicated issue. Not only the dose can make a toxicity, because many cases with a very low dose can make a toxicity. And many cases with double or triple the dose, you don't have any toxicity. It's a complicated issue, and many things behind it. It's not just the dose, but a very important factor to how to what's called to calculate the dose. So it can be mentally calculation if you know, for example, that the maximum dose for lidocaine 5 milligram without adrenaline and 7 milligram with adrenaline. You can calculate it, but mostly on lean body weight. Don't calculate on real body weight. You can calculate it by general calculator, by computerized program, and also there is an app, some apps, Astra apps, how to calculate the dose. There is also research about graphic, how to calculate the dose. And there is many difference in doses for different country, but most of the time the maximum dose for lidocaine without adrenaline 300 milligram, for lidocaine was epinephrine 500 milligram, brilocaine 600 milligram, bupivacaine, and there is many other formula about the per kg for lean body weight. So it is 3 milligram, in some other tablet is 2 milligram. But the idea behind the dose, you give the most minimal dose to give the effect for regional anesthesia. And usually because we are fearing about the failure of a block, just to give more and more, and this is a wrong practice. You know, again, there is many doses, but most of the doses are near to each other. We must speak about many facts about regional anesthesia. You know, must understand the safety about the practice, how to make a safety practice for anesthesia. Not necessarily to be professional anesthesia. You need to be safe more than to be professional. Because loss is a life-threatening complication. And also loss is not related only to the dose, but related to if you inject inside the vein or artery. Sometimes you inject in artery 1 ml in head and neck, you can get a convulsion. And you must follow a guidelines, because guidelines just adjusting our tuning our practice. And to know how the local anesthesia at work and patient assessment is very important, because some comorbidity affecting the dose or the disease, and monitoring just before, even in the operative and post-operative. The local anesthesia is just a drug to block the transmission of the signal to the CNS. So at the end, you don't feel, or just to give you analgesia according to the dose. So we have two types of local anesthesia. I think there is another type coming to the surface soon. But this is a classic. We have the ester group or amide group. There is a lipophilic group, what's called an aromatic group, and the hydrophilic group, and there is a bridge in between. And this linking group, it may be an ester or amide. And this gives the local anesthesia the character, which one is metabolized in the plasma cholinesterase, and the other one is metabolized in the liver. So this is some of the local anesthesia which belong to ester group and amide group. And we use lidocaine. We don't have bupivacaine in our institute. We have lidocaine and levobupivacaine and robuvicaine only because more safety. And we have also brocaine in our institute, which short acting can be used. And also this classified according to it is an potency is low, like brocaine, lidocaine, bupivacaine, intermediate or high. This potency decided by lipid solubility. And this is how the transmission of the nerve and action potential transmitted through the nerve. And this is how the local anesthesia blocks this transmission, working mainly on the sodium channels. So if I speak about pharmacokinetics, I don't need to discuss a lot, but I will speak about BKA, and this is deciding the onset of time. If it's the BKA near to the pH of the blood, it deciding the time of local anesthesia. For example, lidocaine can work very fast more than the other because BKA is nearer to the pH of the blood. Lipophilicity, when just I'm looking for the potency. If you have more lipophilic, they have more affinity to the receptors and give more potency, like bupivacaine. Protein binding, the more protein binding, the more the duration of the local anesthesia. Also, I just give you a small words about pharmacokinetics. Not just only the big plasma level which produce the toxicity, also the time to reach this plasma level. And also again, the free fraction of local anesthesia, which work. And this is subjected to metabolism and subjected to the effect of local anesthesia because the bond part is not working and not metabolized. And also look for the route of local anesthesia. Some route is well known that vascularity is high and can give a very high plasma level. For example, for kids like an benign block or caudal, and for adults like paravertebral or intercostal. This have an extra vascularity in this area, absorption will be very high. And looking for the patient factor like comorbidity, renal disease, liver disease, heart disease. But you know that is a very complex, as I told you, less than toxic dose can make a toxicity and more than toxic dose, no toxicity. And in every now and then we're looking for pharmacogenetics. This is a new term and coming to the surface, and they divide the people for slow metabolizer and rapid metabolizer. And we can see that in our practice, some patient given, for example, 3 milligram morphine, and he sleep and he's about 100 kilogram, and the other about 30 kilogram, give 110 milligram and don't have any effect, because this is as called slow and rapid metabolizer. And also you must know that the sodium channel is more than 10 subtypes, voltage gated sodium channel, more than what's called 10 subtypes. And all the receptors just composed of alpha and delta subunit. Delta alpha subunit is 1 unit, but alpha subunit is 1 unit, and so repeat beta is not delta. Beta subunit is 2 units at least, and everyone have a function. Alpha, this is a passage for the sodium and potassium, but the beta is the modulating mechanism, just excitatory or inhibitory mechanism. And in genetic mutation, for example, like an erythromyalgia, like erythema and pain, they have a mutation of the sodium channel. Paroxysmal severe pain syndrome have a mutation also for this sodium channel. Chronic, like congenital absence of pain, this is a mutation of sodium channel. Epilepsy and congenital cardiac arrhythmia, also this is a mutation, some congenital type mutation of the sodium channels. So this is how local anesthesia work, just going inside the plasma membrane, and it blocks the sodium channel from inside. So sodium receptor blocked and no action potential. But it is not only this action, because this can't explain what happened in toxicity or in action. It also blocks the mitochondria to produce ATP from AMP, and also working on the rhodopsin receptor, which is work also on malignant hyperthermia to block the calcium in sarcomeres. So how to differentiate between local anesthesia, what's called an local anesthesia for ester and amide. Just so you know, amide have an extra I, and this is how the metabolism happen. This is uptake by many routes, just in local routes, spraying, just cream, and all this can be reduced and toxicity. And also this metabolism, the ester one destructed by or just metabolized by ester, non-specific ester in the blood, and the amide extracted by metabolized by liver. And there's many routes just can producing the same effect or as toxicity. And adding vasoconstriction can add some benefit for local anesthesia because it can increase the dose, it can prolong the time, decrease the plasma level, increase the duration, and decrease the bleeding. But still, I have a controversy against use of vasoconstriction, especially if you inject it inside the nerve, you can make a nerve ischemia and nerve injury. So there is more safe additive now. So you must thinking about overdose versus normal dose because it can happen with a normal dose. What about the local what about the toxicity which happen? It is not just local anesthesia systemic toxicity. Toxicity can be localized allergic reaction, myotoxicity, and this is well known in literature now. If you inject in the muscle, high concentration. Neurotoxicity, you can have transient neurological syndrome or permanent neurological syndrome for the nerve, and it most of time just resolve within 6 months. Also, we have another systemic toxicity, which can go into the differential diagnosis of local anesthesia systemic toxicity, and sometimes it's very difficult to differentiate, like anaphylaxis. And this is very uncommon for local anesthesia, but very common for ester local anesthesia. Allergy for methylparaben or metasulfide, maybe for the local anesthesia itself. And some previously last case report, it was only just an anaphylaxis for latex, or just it is an anaphylaxis. And also sometimes when you inject the adrenaline, it can give you tachycardia, hypertension, and sometimes hypotension and arrhythmia. And this is misleading as a local anesthesia systemic toxicity. You know, the fever, this is an allergy started by fever, angioedema, urticaria, dermatitis, hyposensitivity, anaphylaxis, and also it can give an hemodynamic instability. Hemoglobinemia, it is some sort of systemic toxicity for local anesthesia. Usually it happens for some people, and this is related to metabolites. It can be happen for kids and for local skin used. And usually this is a beer persons like a cyanotic, it's called the chocolate brown color. And most of the time given headache, shortness of breath, nausea, rapid heart rate, fatigue, lethargy, confusion, and even unconsciousness. But our topic now is local anesthesia systemic toxicity. It is a systemic toxicity happen to the main organ, which are perfused organs that like an heart and CNS. So it is not a new thing. It is a very old thing. It started with cocaine. And in 1887 is highlighted about last feature for respiratory failure, palpitation, and regular heart rate. And at that time, it affect also the same like neurological and cardiac problems. And was a very wide, but at that time, the management is not clear, given subdermal injection for local anesthesia, caffeine, and mortality was very high. And the manifestation, this is for academic purpose, because they know that the last, like a sneaky, take for some of this symptom, heart and brain symptom or CNS symptom, but this not happen in regular manner like this, because sometimes it's very difficult to diagnose. Usually started if you have a low dose by a circumoral numbness, dizziness, confusion, visual disturbance, followed by seizure, agitation, loss of consciousness. So excitatory and inhibitory. Again, for the heart, it may be an hypertension, hypotension, tachycardia, bradycardia, a lot of circulating dysrhythmia, and usually a systole at the end. So onset of loss is different from time to time. It can happen in a few seconds, 2 minutes if you inject intravenous, intraarterial. It can happen after 1 hour if you injected subcutaneous and also or in an area for high absorption. It can stay for appear after long days if you give an infusion, for example. And this is how to, this is an animal study, how to show with increasing the dose, what happened to the body. But this is not happening in practice. In practice, you can see at any sign, any symptoms at any time. And sometimes you can't diagnose easily. So mechanism of toxicity, whenever you inject the local anesthesia and anything happen to the patient, especially neurological or cardiac, must think in seriously, it is a local anesthesia systemic toxicity until proof otherwise. And starting usually by brain, neurological, and this is only 1/3 of the patient. Also, again, this is decrease the metabolism and catalyst pathway, decrease the sodium channel block, and the effect on mitochondria all the time. And this is how the story happened. And this is my picture when I attended the first lecture about local anesthesia systemic toxicity a few years ago. So, you know that there is extreme from circumoral paresthesia until cardiac arrest. So the cardiac arrest, if it happens, they have another management, not like an ACLS, normal ACLS. There is some tuning to adjust it for this category, because all the animal studies showing that, for example, the optimal oxygenation and ventilation is the most important, because I don't need this patient to go for hypoxia or hypercarbia, acidosis, which increase the severity of the toxicity. Again, if seizure happen, just use benzodiazepine. And benzodiazepine is drug of choice. Don't use an what's called an propofol, except in a very small dose if the patient is still, if you need it, but not on routine. The main drug to use is benzodiazepine. And chest compression, as usual, because this cleared sending the interlipid inside the coronary to make a myotonic effect for the heart to declare the local anesthesia. And use epinephrine, not like an one ampule like other ACLS, 1 mic per kg, because all animal studies showing the high dose of epinephrine is joined to the bad outcome. And rapid institution of rapid emulsion therapy is vital, because it's like an antidote. And this is the case about what had happened, and when they use an intralipid infusion wasn't successful all the time. Most of the time it's successful. As the outcome, if you discover early and use the antidote intralipid, it will be a very good outcome. This is the era. It started very early in the era of cocaine, when the cocaine was used in everything, in wine and in toothpaste. And during this time, about 40 cases recorded from the cocaine overdose, and use caffeine, ammonia, hypodermic ether. Burcaine is manufactured in 1904, and really don't solve the problem, even with the reported 43 cases fatal for use of local anesthesia. Even with lidocaine, it don't solve any problem. In 1928, the American Medical Association reported 40 cases of death attributed to local anesthesia systemic toxicity. Cocaine was responsible about 20. Lidocaine first sensitized in mid the 19th century, but still happened many cases. And Albright just highlighted this issue about that. What is the history about the lipid? Lipid used from 1962 as a total intravenous, but you know the manufacturing of the technology of this look of the interlipid improved, and it used as an animal study for rat by Wimberg in 1998 to use it for kills to give the rat as killing dose or arresting dose for bupivacaine, and to give him the interlipid, and he found a very good result about resuscitation. Also, he used 12 dog and make a randomization, give under anesthesia was hallucine, and give him an arresting dose of bupivacaine, and in half of the dogs he used an interlipid, and all these dogs recover, and the other half of the dog he gives intravenous saline, and no dogs recover. But the first case discovered in 2006 about the use of interlipid for last, and it was successful. And after that, we have many guidelines. 2007, like Anesthesia Association of Great Britain and Ireland MICA guideline, and ASRA and ISURA MICA guideline. But really, we don't know how much this event happened, because we don't have a statistics about that. And statistics different from area to area. It can come from 0 until 20%. 20 per 10,000. But there is a very interesting in Australia and New Zealand database registry about 20,000 cases. They found about 22 cases of local anesthesia systemic toxicity. 13 was mild, 8 major, and 1 cardiac arrest. So the incidence is about 8.87 per 1,000. And the ultrasound is associated, and it's really good news, about 60% reduction of loss. Lidocaine was the highest. This is against what we know is the highest, and the bupivacaine was the least, because they don't use bupivacaine in common, and also because we feel safe about the lidocaine, and it's not right. Don't feel that lidocaine is more safer than the other local anesthesia. So there is other also statistics from Finland and from other area. But this is a very interesting thing. They have in Finland about 59 cases of local anesthesia toxicity and 60 cases mortality. You know that the outcome is more better than the other arrest, but still there is a mortality. One mortality is a bigger thing, you know. And there is how the statistic gone. And the last one in 2018, ultrasound guided, this is about 0.3 to 0.7 per 10,000. And this decreasing was the use of ultrasound. So the risk increasing all the time was usually with catheter, with high volume in facial plain block, or plastic anesthesia when you inject an extra dose, 35 ml per kg, and spraying because non-professional don't count the dose, example for echocardiography, for endoscopy, and long-acting and liposomal form, still we don't have a data. All the data showing that no increased risk was liposomal form. So this is the first case report for lipid use and successful resuscitation. And the discussion and conclusion came was when conventional algorithm of cardiopulmonary resuscitation was unsuccessful for 20 minutes. A member of code team suggested the use of lipid, and this man just was inspired by the work of Wierenberg, administered of 100 ml of 20% lipid emulsion. Lipid emulsion available in area on the hospital from this after this event, and reported the first use of lipid emulsion as a part of successful resuscitation of local anesthesia induced cardiac arrest. And there's a man who's called Bicard. Bicard, no one just speak about him because it's published by other part of the team. And this is considered the antidote like dantrolene for local anesthesia toxicity. Lipid emulsion should be routinely kept in the area in which peripheral nerve block are being performed. And this is, he asked him, this I think is sitting in the state is a Picard, because he asked him how to know this is well worked, because it was just inspired. And they're inspired by the team, because when I is replaced by we, even illness become wellness, Malcolm X. And the immediate management, if you have this case during work, so stop injection of local anesthesia and call for help. Most crisis management call for help. If you don't call for help, you make a big mistake. Then concentrate in airway, breathing, circulation like the other. And you give oxygen, take care about respiration, about obstruction. Cardiac arrest, cardiopulmonary resuscitation started immediately if you have a cardiac arrest. If the patient is still in cardiac still have a cardiac output, 100% oxygen and airway secured as necessary. Seizure treated by benzodiazepine, Stybental or propofol, but this is have a question about this to drug because this is a cardio-depressant drug. Arrhythmia, conduction block, and hypotension, bradycardia can be treated by conventional ALS protocol. Lidocaine and other local anesthesia avoided even for antiarrhythmic. Epinephrine may better be used in a very small dose. Varenicline is best avoided. Beta blocker and calcium channel blocker, don't use it. The only drug for arrhythmia can be used amiodarone. This is the only drug, and this is the drug to use or not to use. So you have in special cases like a pregnant woman who have a special a change in her body and her hormones, producing or accentuated the toxicity. So it is and the problem, this is a local anesthesia, prefer mostly of anesthesia and obstetric. And this is carry a very predictive risk for the users. Pregnancy increases the sensitivity for local anesthesia because the progesterone increases the sensitivity for heart and arrhythmia, and also decrease protein binding because hemodilution. Increase the risk of arrhythmia to hormonal effect, as I told you about estrogen and progesterone. Increase neural sensitivity and due to this hormonal change, and also the hyperdynamic circulation, which carries the local anesthesia more and more. Encouragement of the epidural vein and even other part of the body veins, you know. And in last in pregnancy, early recognition and promote airway management is essential. And you must know, whenever you give a local anesthesia and you found any hemodynamic or just an agitation or just an neural problems, this is local anesthesia toxicity until proved otherwise. Infusion lipid immediately. Position the patient to left side, reduce autocoval compression because resuscitation will not work if you leave it in the position, and activate what's called active protocol for delivery in 4 to 5 minutes in post-maternal cardiac arrest. So there is many standardization coming after that to make a practice standard. And this is guidelines for everyone: immediate airway management, SLS, intravenous lipid immersion. This is the most important issue. And this guidelines is evaluated and updated, and last one from ASTRA 2020. But this is a picture for some guidelines from NYSURA, from ASTRA, from AACBI. And this is the last one from ASTRA. No change, no bigger change. Some people just write the maximum dose 12, some people write 10, and they don't know what is optimal, because this is was an animal study. And this is also other guidelines, the same. But what about the evidence? If we speak about the evidence, according to our recent study, marriage is the main reason behind divorce. So we have a very good evidence about that or not? Really, we don't have still a good evidence about use of interlipid or resuscitation. Even we have a very good surviving people about interlipid, because it is the only case report or case series, and it take a very long time until you prove a good evidence. But nothing, don't speak me about the evidence. If I ask you about the randomized control study about the oximeter, there is no randomized control study about oximeter. And all people become a standard in ASA, and all people just use it without standardization, without an evidence. So all the time, don't speak about evidence, speak about the life of the patient, and this is need a time, because as absence of evidence is not an evidence of absence, because it need a time, it need a more study. And the randomization in this category is like you send the one with parachute and one without parachute to see if the parachute will save a life or not, because we can't make this study. It is not visible and not ethical to see to make a randomization for this study. All the study is an animal study. And what is practicing in animal, not necessary to transmit to the human, but some transmit to the human to save a life with the local anesthesia. And as I told you that this study is done by 12 dogs to see, and we see that the interlipid save all the lives of dogs. This is also another study about use of local anesthesia system to see for the was a patient who had albuminemia, and this patient saved completely by interlipid. Many cases, many cases and publication, and ultrasound sometimes decrease the incidence, but not abolish the complication completely. But to know that protocol of lipid emulsion is very important in the hospital. Local anesthesia systemic toxicity, we have many cases about user and successful block. So fat, not all the time fat is dangerous. Fat sometimes beneficial. Everything have two aspects, So how is this local interlipid work? It's called the lipid sink. This is an old theory, but the new theory is a lipid shuttle. This decreases the lipid from vessel-rich group to transmit it to the very capacious other area like muscle, bone, and the blood and liver. But at the end, that Webner make a study for radioactive labeled bupivacaine, and he found all this lipid just sucked to the interlipid and decrease the level, and also they have myotonic effect on the heart. So if you make a resuscitation and interlipid going to the coronary, it can make a myotonic effect on the heart, and for catalase, and also increasing the AMB and ATP for the cells. Because and the lipid emulsion and the cardiac arrest, that in the first case was 2006, but after that it became like a standard, and very fast become like a standard use, like an antidote. Well, how to use it, and this is a mechanism how to use, how it works. It's like a lipid sink or just cleaning, or like a scavenging system for the local anesthesia, but you must give it early. Local anesthesia, what's called lipid use from 1962 as PBN, but 2006 first human trials. Before that, it was just animal trials. As for guidelines, we can make guidelines, make 1.5 ml per kg bolus of 20% intravenous lipid over 1 minute. Or 2 to 3 minutes. It's about 100 ml for 70 kilograms. And to continue for infusion 0.5 ml per kg per minute, about 200 or 250 ml per hour, or just per 30 minutes. And there is no agreement a lot about this, because it's all animal study. And when just such the dose are just the dose for animal, the killing dose of animal or affecting dose of animal is about 2 times to 3 times what we use in humans. If cardiac instability still, just give 2 times or 3 times the bolus again, increase infusion to 0.5 ml per kg per minute, and you must continue for 10 minutes after hemodynamic stability. And the maximum dose written in some guidelines 10 and in the first 30 minutes, and sometimes it's right 12, but no agreement about that. So prevention more better than cure. You know that what I'm scaring about to use an lipid on high dose or something like this, because I have many questions to ask about lipid, because we don't have a lot of data about it. What is the bulk complication of lipid infusion for? We know that the lipid infusion in TBN, but what is the possible complication? We don't know. Should lipid be used alone or with epinephrine, which is better? And the other component of further resuscitation measure, we don't know, because this is just a case report and animal study. What is the better, to be 20% or 30% lipid? We don't know. Any better choice than lipid? We don't know. Do the other available lipid emulsion work as well? We don't know. If it fails, what the maximum dose? What we can give more? So there is many questions about the lipid, and this is an area for research. So what is the complication? It is allergy, hyperthermia, DVT, and all this complication came from interlipid for nutrition, not for because there is no data, no case report about it. Pancreatitis, thrombophlebitis, also pulmonary hypertension. And many questions to be asked about the lipid. This is a safe upper limit of the dose. Is this protocol is right or wrong? We don't know. Why just all people deciding about this with the animal study? We don't know. And what is the toxicity return back? What we can do? There is many questions to be done, and there is many argument about that. So the aim of argument is, or the discussion should not be victory, but progress all the time. And risk factor for toxicity, the local anesthesia itself. Some local anesthesia is more dangerous than the other, because for example, bupivacaine, the potency and lipid solubility is very high. And also there is a patient-related factor, not just an local anesthesia-related factor. There is a patient-related factor, like an patient comorbidity. Well known that hypoalbuminemia, liver, kidney disease affecting the dose. All the age, young and old. Young, you don't have a binding protein for local anesthesia, and don't have a well-developed liver. The old man have a comorbidity and decreased muscle bulk. Sex, it is common, female more than male. Physiological state, pregnancy can affect in the local anesthesia body weight. Also, the site of block, well known that some areas more than the other, like an paravertebral, intercostal, upper limb more than lower limb. In some kids group, like an pediatric, caudal epidural and penile block is more than the other. Also single versus continuous infusion usually more. And this is to show this some block is more than the other. Also conduct of the block is very important. You must factor decreasing the risk, like frequent aspiration. Don't be overconfident all the time. And don't get a shortcuts. You do practice every day. Don't get a shortcuts. And frequent aspiration, increment injection, test dose, trace like epinephrine and controversial, and the ultrasound-guided nerve block, it can help in to prevent. During preoperative assessment, you must, as I told you, it is not necessary to make up regional anesthesia. Risk, benefit, and regional anesthesia versus general anesthesia will be discussed. Explanation of procedure improves the patient cooperation is very important. Assessing the morbidity, and also make a plan B. Prevention during the procedure, the block and bliss room. This is an operation. It must be in some sitting area. You have everything in the room. You have a resuscitation tray in the room. Surgeon must be labeled, because sometimes a mistake happen from the labeling. And choice of local anesthesia should be considered in advance about the patient, about everything to calculate it. Sufficient dose to make an effective block, not to cause a loss, because some people feel less confident and make more dose to get an effective block. And patient vital sign monitoring continuous during block. Interaction with the patient all the time, because sometimes you lose the patient and don't feel it. Ultrasound, it proves that it decreases the incidence of toxicity, but not abolishing, because you directly visualize the nerve and the vessels around. detection of intentional intravascular injection. Also for the ultrasound, use a very minimal dose, not like a blind technique or peripheral nerve technique. Post-procedure nerve block catheter and epidural technique must be labeled. Endorsement is very important because sometimes a mistake happens from a miscommunication and misconnection for the block. And presence of catheter should be communicated clearly. Now there is now epidural can't be fit for IV, and go and monitor is vital as a case delayed. Sometimes take a very long time to appear. And awareness very important. To awareness for the other professional and make like a simulation for other people working with you and working for other specialty like surgeon, people for cardiology, for echo, because most of those people don't care about the dose and about anything. And this is patient follow-up is very important to see the clinical condition and sign and monitoring. Pancreatitis, sometimes if it happens with intralipid, abdominal CT may be required in some cases. And also a very important issue to make a reporting. Really, we don't have in our country here a reporting system. So you must be reported, and training education checklisting is very important because it is done in very all industry like aviation industry, nuclear weapon industry, because it can help. From checklisting, you can know that this house to be standard, you need some more rubber to support it. Ongoing research, many questions remain still regarding novel treatment, optimal dose, and no one using epinephrine cardiac arrest. Another question was about interlipid. Infusion of interlipid also have a benefit or other toxicity. Aim of the research, many, as I told you, there is many area for research for that. I know time is squeezing. What's my conclusion? Last local assessment toxicity occur in 20 per 10,000 per block at maybe from 0 to 20. Half of the cases last no CNS symptoms. I must care about this. Half of the cases can be cardiac only, cardiac arrest immediately. Incidence of toxicity increase with injections near ritual vascular area, prevention, awareness, education, proper use of local anesthesia, very important. Last is rare, not always on the differential diagnosis, and very important because there is nothing just to test to see, for example, X-ray or lab. Last are general and predictable but preventable. Clinician must be awake, make every effort to avoid this emergency. If last happen, recognize and institute appropriate management. Lipid emulsion therapy is the best for the last. Cardiovascular neurological sign after local anesthesia, it lasts until proof otherwise. The risk of loss is influenced by patient factors, the site, conduct of the block, and local anesthesia type and dose. There are post-procedure measures to reduce the risk of local anesthesia toxicity. Education is very important for the patient safety and for your safety. Checklisting is very important as all other industry. At the end, prevention of loss, optimize a complete setting for your regular anesthesia, patient selection, block choice, drug and dose, complete monitoring, use of ultrasound guided when possible. Last cases must be available everywhere. All what we need is a quality of life for the patient and also quality of life for you. And because we never subjected to the stress as a doctor, but this is Jimmy, 28 years old, and want to start a new beginning in this year, inshallah, and to be away from Corona. And thank you very much for your attending. And there's my presentation, awesome, outstanding, magnificent, all of the above. And for any question, you can just go for Google to ask him because he knows more better than me, but I'm just born before him. I'm ready for question, I'm joking only.
Thank you very much, Dr. Yasser. That was very comprehensive. Actually, I've got a couple of questions for you, but since we're pressed for time, I will have to choose only 2 or 3 questions. So starting with the first question, doing regional anesthesia under general anesthesia, how can we pick up the local anesthetic systemic toxicity early?
You know that, as I told you, this is most of the time, you don't see the neurological effect. If the patient is sleeping, you don't see a convulsion with the same most common symptom you see. It's about 70% of the case you can see twitches of convulsion. So what you see if you give local anesthesia under regional anesthesia, first thing you see is hemodynamic instability. If you see hemodynamic instability, don't wait. Just use an intralipid because you know that the risk benefit to use an intralipid. So if you found hemodynamic instability, because this is a high threshold for the local anesthesia to do that, just start interlipid. And there is no harm because we use this for kids all the time for pediatric. with it for pediatric. And if you found, just use an intralipid. You have now an antidote.
Okay, thank you for that. Next question. If you are using a mixture of 2 drugs for local anesthesia, how can you calculate the toxic dose in such a mixture?
You know that the mixing is not now is not a common practice, because there is a many factor guiding you how to choose the local anesthesia. For example, if you need this local anesthesia for osteotome, myotome, or dermatome. For osteotome, you need a long acting. So second thing, this operation is a long operation, short operation. Third thing, this is a day case surgery, or just a patient will go home and can injure his limb for a long time. Third thing, the comorbidity of the patient. Fourth thing is the body weight of the patient. So mixing is not a good thing, because most of the cases was discovered about local anesthesia systemic toxicity. It was a mixing, because sometimes you lost the mixing. And no one used mixing like before, because I have something to mix now. We have an even outside the box as mixing, like an dexamethasone, like dexamethasone. This can increase the time. Buterphenone can increase the time. So mixing, you have a problem, because sometimes, you know that I have I just read a paper about 2 case report from a military hospital in Vietnam. The people all the time make a mistake about the dose. The patient is 50 kilogram, he give him 300, this is the maximum, and he give about 100 milligram robuvicaine. And the conclusion came at the end, mixing sometimes make a confusion. So we don't like to mix, because the era about mixing to give lidocaine with the bupivacaine to work fast and to give a long time. This not happen in practice. What happened is give you unpredictable time. Because what happened in logic is not happening in practice. Now, if you need it for a long time, use for a long time, need it for short time, not for short time. So difficult to count this toxic dose with a tool.
All right. Question saying safe doses in tumescent anesthesia.
Yeah, you know that before they write about, this is a very, very high dose beyond our expectation. It was 55 milligram per kg. Now, they found this 35 milligram per kg is a little more severe, but the less you give, the less you get a loss. But it can happen. It can happen if you inject some in intravascular, or you are unlucky to inject intravascular, because you know that there is many doses, but the doses accepting now is to publish 2020 about 35 milligram per kg.
Right, I think we should stop here because we're pressed for time. And thank you very much, Dr. Yasser.